All right, good afternoon, everybody. I think we've got most folks logged in now. I appreciate you all joining us. My name is Jonathan Shivers. I'm the Chief Business Development Officer for CareOptimize. We have our Insights webinars at least once a month, try to do them twice a month, depending on what is going on in the industry at the time and any types of valuable resources that we can put out there for you. Today, we're going to be talking about the 2019 MIPS final rule. I'd like to start with an apology. I sent an invite out for the proposed rule, and then CMS went ahead and approved the rule and made the final ruling, so it is no longer proposed, but it is actually the final rule that we will be covering today. Get my presentation up here. This will run us about 30 minutes. And this is meant to be a high-level overview of the significant portions from 2018 that are going to carry forward to 2019, and additionally the changes that we're going to see in 2019. This presentation will be sent to our website, to our Insights page. So within a day or two, you can always go onto our website at careoptimize.com and view all of our past recordings. Again, this one will be up within a day or two. At the conclusion, if anyone does have any specific questions, I'm going to have my email address available, and I will be around for the rest of today and tomorrow to answer any questions that you might have. With a program like MIPS, it's going to be, from our experience, very different questions based on your practice, your specialty, your measures, your size of practice, how you want to submit. And so for the sake of everyone's time, we found that it's best to do the follow-up by email, and then we can jump on a call if you want to get with our team on specifics. So I'll jump right in. Today we're going to discuss the final rule, no longer the proposed rule, for MIPS 2019. Today, we're going to do an overview of what some of the main changes are, as well as some of the carryovers from 2018 that will also be relevant in 2019 that haven't changed. And then we're going to look into each of the four categories to talk about what the most relevant changes are. There is a section in here that is facility-based, that is brand new, that will affect both the quality and the cost section that we'll spend quite a bit of time on as well. So CMS is as most of you probably heard from CMA Vera, is the patients over paperwork initiative is something that keeps coming to the surface of most of the documentation that we have been reading. The 2,300-page final rule that came out the afternoon of November 1st had this peppered all through it. Is the changes that they are making, the whole purpose is to emphasize this patient over paperwork initiative. The bullet points below are the main themes that we continue seeing, and that CMS really has tried to emphasize throughout the 2019 final ruling. So you'll see a lot of these come up as we start talking about the changes, and as more of them get well defined over the next year, CMS is dedicated to keep these main 5 bullets I guess in their main site of vision or main line of vision, to make sure that patients are continuing to be the main focus with the MIPS program. A quick look at the timeline. So no surprise there. The performance period, just like the 17 and this year, is going to run from 1st of January to the end of December. You'll have until March 31st of 2020 to submit for 2019. CMS is requesting groups to submit early. Obviously, that helps them quite a bit. There will be a feedback portion and then the final adjustments just like you're used to, will from last year and this year are going to start 2 years January 1st. I found this interesting in one of the summaries of the final ruling was that originally there was around 650,000 eligible clinicians that CMS believed would need to participate in MIPS in 2019. This was during the proposed rule they released, I believe it was in July of this year. Fast forward till November 1st, just a few days ago, and with the rules that have been put in place now that we're going to walk through, now 800,000 clinicians. So that's an additional 150,000, which is very significant. So they made a point to make sure that everyone who reads this final ruling is aware that it is going to affect more clinicians than people originally thought. From 2017, we're seeing numbers that show that about 90 to 91% of eligible clinicians did participate in the MIPS program, which is slightly higher than what CMS had thought. But I have a feeling that number may be even a little higher around 2019, since so many more are going to be required to participate. As far as the distributions will go, CMS is estimating a negative adjustment of $390 million and a positive of $390 million. And then the additional $500 million will come into play again this year for those who exceed, that high threshold. All right, let's start with eligibility. So this year, you can see on the left-hand side of your screen, you've got physicians, PAs, and Ps, CRNAs, and nurse specialists who are all eligible for this year, 2018. In 2019, they have confirmed that all 5 of those types of providers will also be eligible. Additionally, they have added a whole slew here of different types of therapists, psychologists. The one on the bottom is new as well. The registered dietitians and nutrition professionals are also added for 2019. So again, I think the addition of the eligible clinicians there is a large reason why that 800,000 number is 150 over what they had originally estimated. Okay, new for 2019 are the minimum thresholds. So all of you are probably aware of the first 2, that just like 2018, you need to bill more than $90,000 in Medicare allowable charges, and you must provide service for at least 200 different Medicare beneficiaries. You must check both those boxes in 2018 to be an eligible clinician. Starting in 2019, they've added the 3rd threshold, and that is you must meet numbers 1 and 2 and number 3, which is at least 200 covered professional services. So you must meet all 3 of those to be eligible in 2019. Now, what's interesting is in 2019 will be the first time they are going to allow an opt-in policy. So what this means is you may have providers in your practice who don't meet all 3 that we just looked at. They might meet 2 of the 3. Maybe they just meet the first 2, but they don't meet the 3rd. So they've got the dollar amount and the Medicare beneficiaries of at least 200. But if they didn't meet the 3rd, they would not have to participate. Well, now you can choose to participate even if you don't meet all 3 of those thresholds. So as long as you meet 1, you are able to participate. So again, if you meet none of them, this does not apply to you. But if you meet at least 1, then you are able to opt in. However, once you opt in, you cannot opt out for that year. So please think about that really carefully. If any of you have providers that would meet this criteria, it is applicable whether you want to do it on an individual or a group level. But remember, you will be eligible for the bonus. You will also be eligible for a negative adjustment. So keep that in mind. If you think you can do well, by all means, go for it. If not, I would urge you to be very cautious. So that is a new policy that they've passed for 2019. Another change, no surprise, is the adjustment amounts. So we started at 4% in our first year. Currently, we're in a plus or minus 5%. And next year, it goes up substantially to plus or minus 7% for the adjustment. Again, this does not include the $500 million additional dollars that they have earmarked for the exceptional performers. So you've got the 7 plus and 7 down, and you've also got the $500 million. Okay. The performance thresholds have also increased. This is a big one. This is going to affect a lot of groups who are just squeaking by doing the minimum. So if you were not trying to max out your score, this may be the most important slide to you in this presentation. Your minimum score now is now going to double, meaning you have to have at least a 30 as a score to avoid a negative payment. So that means that just submitting one category, not going to cut it anymore. So you can't do just your improvement activity or just your promoting of interoperability, your PI. You would have to do multiple categories to get above that 30 score if you're going to choose either the IA or the PI. Now it's an and if that's what you did in the past. Again, you cannot just do an IA measure or PI. Also, the exceptional reporting bonus is going to go from 70 to 75. So to get to that $500 million earmark, you now have to be above a 75 for 2019. Not changing this year. From 2019, it's going to stay the same as this year in 2018. Your performance periods, you're still going to need to report 12 months the entire year for your cost and your quality categories. And then for your improvement activities and interoperability, you're going to have to report on a continuous 90 days for each of those. So no change there. Before we jump specifically into each category, look at an overview of the weights. Again, this wasn't a surprise. The quality will go down by 5 percentage points, and the cost quality will be going up by 5 percentage points in 2019. So no change to the proposed rule there. Okay, so as we start to jump into these specific categories, it's important that you know that just like this year, next year you will have to have 60% of your patients to meet that data completeness minimum. And new for this year is if you're not meeting the CAPS sample requirements and you're submitting less than 5 quality measures, then you're not going to get any points for that measure, and your quality denominator is going to go down by 10 points. So that's brand new for this year. So if that does apply to any of you, please take heed. You may want to spend some time looking at that because that can adversely affect you if you're not aware. All right, so our first category. So in quality, again, 45%, so it's going to go from 50 to 45, and it's going to maintain the same reweighting criteria from the quality performance category. You're going to need to select 6 individual measures. You're going to, again, have to pick a high priority or one outcome, and they will also allow you to go with specialty-specific set of measures if you need to. You are able in the quality category to earn bonus points, and the bonus points do not change from this year to next year. So those are all staying the same. And the biggest change for small practices in the quality category is they proposed in July of this year to do 3 points for the bonus. However, they have decided to double that to help the smaller practices and make that 6 points for your eligible clinicians if you submit at least one quality measure. So if you have 15 or less eligible clinicians, congratulations, your small practice and your bonus is now, instead of 3 points, going to go to 6 points. However, that small practice bonus in 2019 is only going to be attributed to your quality category. No longer will it go to your overall score. I'm going to say that again. The small practice bonus is only going to be going to your quality category score. No longer does it go to the overall score as it did in years past. Okay, the improvement scoring, that's not going to change. So as you can see here, if your performance category is less than or equal 30%, then they're just going to compare it to the previous year, which in this case would be this year's performance. So not really a change from last year to this year for your improvement scorings. Okay, topped-out measures. What's going to stay the same? You're going to have a scoring cap of 7 points for topped-out measures, and they're going to have a full-year life cycle if they want to remove these topped-out measures. What's changed for this upcoming year is that CMS is calling them extremely topped out, is their name for them, extremely topped out measures, and they could pull those out in the next ruling cycle, and that's going to be anything that's from the 98th to 100th percentile. Again, nothing really ground shaking for anyone, I don't think, but still good to know that those that are that high will get pulled out in the next cycle. Okay, let's move over. You know what, actually, before we move over, there were a couple other things I wanted to talk about. The end-to-end electronic reporting, that's going to stay the same as this year. Your improvement scoring, that's going to stay the same as this year. So you do still have quite a few bonus options in the quality category. Okay, in the cost category, this is increasing from 10% this year to 15% next year in 2019. The two measures, I should say, that are used are the total per capita cost, and the second is the Medicare spending per beneficiary. Those are the two measures that are used. This data, it comes from your Medicare claims, so it's nothing that you need to submit. CMS has access to your Medicare claims, obviously, so the burden is off of you there. And the measures that are used, again, same as last year. The MSPB and the total per capita cost, those are not changing. They are going to add 8 episode-based measures. That is new. And there's going to be a case minimum of 10 will be the minimum for procedural episodes, and 20 will be the minimum for acute inpatient medical episodes. Okay, so the definition seems to trip a lot of people up. What's the difference between the MSPB and the total per capita cost? So I took the definitions here just to help clarify some of this. The total per capita cost, so think of that as the primary care services that are rendered by each clinician. The MSPB, the Medicare spending per beneficiary, think of that as the services are billed during the admission time. Okay, so important distinction between those two. That question comes up quite a bit. A couple updates CMS has made for this cost category. The first is they're going to be attributing the episodes to the clinician that performs the procedures. So for the procedural episodes that we talked about, remember the minimum of 10, it gets attributed to the clinician that performs that procedure. The second is for the acute inpatient medical side. where this has a minimum of 20 different episodes, they're going to attribute it to the clinician that bills at least 30% of the inpatient E&M during that patient's hospitalization. Bit confusing, but they're just further defining those terms and how they're going to be attributing. Okay, so the facility-based quality and cost categories. This is probably something you haven't heard of. This is new, and this is a very interesting option that CMS is allowing. So the gist is that if you have providers and they do their work in a hospital setting, they could be allowed, if they meet thresholds, could be allowed to have both their cost and their quality performance scores. Instead of just based on them, it's based on the performance of the hospital where they are performing those services. So to be eligible, the group would have to have 75% or more of those clinicians under that 10 that are measured as individuals. Okay, so as long as they're facility-based measures as individuals and it's greater than 75%, you could opt for the facility-based quality and cost scoring mechanism. All right, so if the individual, so not looking at the group, let's look at the individual, if you have over 75% of your services are inpatient, so you've got a place of service as a 21, 22, or 23, and it's within that claims and it's based on the claims for a period prior to that performance period, then you are eligible. So as long as you've got greater than 75% inpatient hospital and you've got a 21, 22, or 23 as your place of service. You also would have to have at least a single service billed with a place of service code for an inpatient or an emergency room. Okay, so if you're looking at it individually, not group, you've got to hit that 75% number. Okay. So attribution. So the individual clinician, their attribution is based on the hospital where it's provided to the greatest number of their patients. So if they see patients in multiple hospitals, the attribution goes to the hospital where most of their patients are seen. For group, it's going to be attributed to where most of the facility-based clinicians are attributed, not necessarily to the patient, but to where most of the clinicians are being attributed. And finally, if they're not able to use the VBP score, if it doesn't exist to see a performance, then they're not going to be eligible. So you will not be able to use the facility-based metrics or mechanism if the VBP cannot be determined. Okay. All right, and finally in this area, how they're going to be scoring. So the scoring for the facility-based clinicians is going to be how well clinicians' hospitals perform in comparison to other hospitals that are in the program. So this obviously has not been made public yet, so we don't know what it's going to be. So it is a bit of a risk. And again, if they don't receive that VBP, you're going to have to choose another method. You cannot use the facility-based. So very interesting option that CMS is making available, but I know, at least for a lot of our clients, that might come into play because I know they work with multiple hospital locations. So something interesting to think about if that's going to apply to your providers. Okay, the Promoting Interoperability category. I know I've written it's new for 2019, but the first piece does not change. It's still going to stay at 25% of your score. And the biggest change here is that you are going to have to use a 2015 certified EHR. Okay, so for promoting interoperability, the old ACI category, you must use a 2015 certified EHR. Your performance-based scoring is going to be at the individual level. Each measure is going to be based on the eligible clinician's performance based on the numerator or denominator, or it could be a yes or no. And this, I'm sure most people saw coming, was the security risk analysis that has to be done that most groups do every year for their measure. It is now going to be required, but you will not get any points for it. So in 2017 and 2018, all of our clients and all of you who are on this call that are not clients, you got points for doing your SRA. In 2019, sorry, you're still going to have to do it, but CMS will not attribute any points to you for doing it. Okay, there are going to be 4 objectives that clinicians must report on in 2019. So you can see them there at the bottom of the slide. You've got HIE, you've got e-prescribing, the provider-to-patient exchange, and then your public health exchange, public health and clinical data exchange. There is going to be some re-weighting, and your scoring is going to be eliminating base, performance, and bonus scores. So today, you've got weights for your base, weights for your performance, and then weights for your bonus, and that will all be re-weighted. We don't know what it's going to be yet, but they are still finalizing the new scoring methodology. We do know those 3 separate weights are going to be eliminated. Okay. So again, CMS hasn't said what the new weighting is going to be, but we do know it will not be as you're used to it in 2017 and as you're used to it today. All right, and finally, your improvement activities. So again, I know I wrote new, but this 15% is going to be the same as last year. They have added 6 improvement activities for 2019. They are removing a couple, but they will add 6 new activities. And it will no longer have your bonus for using a 2015 EHR technology that's certified. It is now a requirement in the previous category. So obviously they will not be offering the bonus that they did last year and for this year. Okay. Your data submission option. So this is a big change. Last year in 2017 and in this year, groups were not able to select multiple submission methods. In 2019, they will allow multiple methods for submission. So as you can see on this list, groups just have, they have some more options, which is nice. I know a lot of groups will take advantage of that. But all in all, it's just trying to give groups more flexibility than they did in previous years. Okay, so that is all that I have prepared for us today. I hope this high-level overview was helpful. A couple things before we end, though. Again, this final rule is over 2,000 pages, and there is a lot in there. If you do have specific questions and you want to talk about your practice specifically, or you want to talk about certain categories specifically, this is my email address. Please send me an email. I am more than happy to spend time one-on-one and talk about some of the more specifics. I was trying to squeeze everything into 30 minutes here. So please let me know if you have any questions. I will leave this up for a few moments. And again, if you want a copy of this, it will be posted on our website here in a few days. So I will end the webinar now, but I will leave this up for a few moments if anyone would like to reach out to me. So thank you so much, everyone, for joining, and we will see you all again in a few weeks for our next insight. Thank you so much, and have a great afternoon.